Good afternoon, everyone. Thank you so much for joining us for another Friday in an ECTR Spring Seminar Series. My name is Liz Charnetsky. I'm a faculty scientist at Maine Health Institute for Research, and I'm going to be helping to moderate today's session on implementation science. We are joined by Dr. Jeremiah Brown, who's the founding director of the Dartmouth Center for Implementation Science. Before I introduce Dr. Brown, I'll go over just a few pieces of housekeeping that we have. First thing, please, as you are listening, if you have questions, feel free to drop them in the chat, or we will have a Q&A at the end of Dr. Brown's talk. So you can raise your hand and I will help to facilitate our conversation. If you would rather say your question out loud and not drop it in the chat, that's fine. So hold questions till the end or drop them in the chat and I'll keep a log of them. And then I believe that today's session is going to be recorded and available on our website for anyone who would like to access it later, or for those of you who have colleagues who are unable to attend today's session. I think that's all of our housekeeping items, so I'll go ahead and introduce Dr. Brown. As I mentioned, Dr. Brown is the founding director of the Dartmouth Center for Implementation Science, which was established to develop an academic home at Dartmouth to accelerate implementation science trials and research. He recently founded one of the first master's programs in implementation science hosted at the Geisel School of Medicine at Dartmouth. He is a tenured professor of epidemiology with joint appointments in biomedical data science and health policy and clinical practice, and was the recent NIH study section chair for the science of implementation in health and healthcare. Let's see, Dr. Brown has experience as well in predictive analytics using our structured and unstructured EHR data for using in developing healthcare informatics, predictive toolkits, clinical decision support, and clinical facing informatics implementation. So much expertise. That was a mouthful, but I'm sure we're going to learn all about it from Dr. Brown, who I am happy to turn this over to now. Thank you so much for joining us.
Great. Thank you, Liz, for the introduction. It's an honor and privilege to be speaking to you today. So I will be sharing about understanding and applying implementation science with some clinical applications. So this is my disclosure. It includes our active NIH funding, past NIH funding, and consultancies with Bracco, Roivos, and advisory committees with Roche. I won't be discussing any of their devices or content today. So we're going to start with giving you a brief introduction to the field of implementation science. Then we'll move on to giving you a little bit of the background of developing and what we're doing for the Center and educational programs for implementation science at Dartmouth. And then I'll spend most of the time giving you a clinical application of implementation science in the context of cardiac catheterization procedures and acute kidney injury. So let's move on to give a broad introduction to implementation science. So the field evaluates multi-level factors and processes that influence implementation. It develops and tests strategies to overcome barriers to adoption, integration, and sustainability, and also brings evidence-based practice or interventions to scale and addresses their underuse. The field has really been meant to address this ongoing 17-year odyssey or problem, where it takes 17 years to turn about 14% of original research or patents into services that are routinely used by in community centers or in routine clinical practice. So implementation science, in doing so, has really developed to sort of help address the 17-year evidence change to practice gap, and really focuses on taking what we know and trying to cross the chasm to do the actual practice of what we know. So taking evidence-based interventions and practice and making it routine clinical practice. The field is informed by multidisciplinary influences, including intervention effectiveness and process research, healthcare and behavioral economics, medical anthropology, organization and process management, social psychology, adult learning and education, and the improvement sciences or healthcare improvement. So this is a very sort of general summary of what is implementation science. So the intervention or practice or innovation that we're talking about or you might think about, we consider it sort of the thing. And then when we talk about effectiveness research, looks at whether the thing works and whether it works in real-time practice. And implementation research specifically looks at how best to help people or places do the thing. And implementation strategies are the stuff we do to try to help people and places do the thing. And also, we might be talking about sort of the main implementation outcomes. So, not clinical outcomes or effectiveness outcomes, but implementation outcomes are really how much and how well they do the thing of interest. So, hopefully, that sort of lays the playing field about the things that we're interested in sort of adopting in routine clinical practice. So when we think about sort of the translational pipeline and you start with some pre-intervention work or testing some things out, usually those things, if they work in a local context, or if a device or drug is being developed, you're moving it on to robust clinical trials. And those are efficacy trials, and they ask the question, could a program or could a thing work? And then if it does, you move it on to test it in the real world. So you do effectiveness studies, and that focuses on the question, does a program work? And what implementation research and science does, which tries to work across the translational pipeline, but really focuses on sort of how we make a program work and how we overcome barriers or leverage facilitators for adoption of the thing or evidence-based practice of interest. So this looks at the progression of research methods to improve overall public health. So the first version of this was to start with your preclinical research and move on to your classic randomized trials or efficacy studies. And that was originally thought to sort of really move the dial on improving public health. But as we know, it didn't. So then, about a couple decades ago, we focused more on effectiveness studies, building them into this progression pipeline, and adding in effectiveness studies and evaluating what was done in randomized trials was thought to sort of help improve public health and really focus on more the adoption of the thing of interest. And it helped a little bit, but there's still substantial gaps in sort of these interventions or things of interest into adoption in routine clinical practice or routine practice. And so now we're in this third version of this pipeline where implementation research and studies, and I'll speak to you about some of those, which are these hybrid designs and other pragmatic studies, are incorporated into this pipeline to really help accelerate the adoption of evidence-based practices and interventions into routine clinical practice and routine practice to improve overall public health. And I think we're making a little bit of progress there and trying to reduce the time to adoption of evidence-based interventions. So this is a subway diagram that was developed by Megan Lane Fall and others to really sort of help relate how you sort of work along a pipeline to do implementation research. So you start with your practice of interest or your thing. Ideally, you have efficacy studies. If you don't, then you sort of have to go back and do the efficacy research. If you have those trials that have been done and it's shown to be efficacious, you can move on to effectiveness studies and test things out in the real world. And so Jeff Curran, who's also teaching our program, developed these three types of hybrid designs, hybrid type 1, 2, and 3, and they really sort of vary in terms of the level of focus on effectiveness outcomes more towards hybrid type 1s and implementation outcomes as the priority for hybrid type 3s. So if you don't have effectiveness studies or you only have some partial real world testing of it, you really need to do a rigorous hybrid type 1. And what I'm going to share with you about the Improve AKI trial that we did is an example of a hybrid type 1, where we're prioritizing our effectiveness and clinical outcomes. And secondarily, we're looking at some implementation outcomes. Now, if you have established effectiveness or you've completed a hybrid type 1, or there's effectiveness from other trial work, you can move on to a hybrid type 2, which is not as often used, which balances effectiveness and implementation outcomes as sort of both primary endpoints. Or a hybrid type 3, which is much more rapid dissemination of your thing of interest. Since you've established both the efficacy and effectiveness, the focus primarily is on the implementation outcomes, really about how we measure the actual use of the thing or the intervention or evidence-based practice. And so that's the focus of the hybrid type 3. And I'll give you a little bit of an example of how we would translate what we did in the Improve AKI to a hybrid type 3 at the end. One of the main reasons for launching the Center for Implementation Science and even the master's program that I'll speak to you briefly about is that federal funding for implementation research, if you are not aware, has been rapidly increasing over the past 20 years and mostly over the past 10 years. It is growing at a rate of doubling every 2 to 3 years. And the most current fiscal year that we pulled in December was up to $4.6 billion annually in implementation research being funded by the NIH, CDC, and other federal bodies. So it's a big deal. So that was used to launch the Center for Implementation Science to address a scientific gap at Dartmouth and collaborators. And the center is also co-led by Kelly Ashbrenner and Sarah Lord as co-directors. We have Julia Shaw, who's Director of Research and Programs, and Gail Cohn, who's the Masters of Science Program Director. It was launched with broad support across Dartmouth and all of our professional schools and undergraduate bodies as well. And as Liz mentioned in my introduction, the center really aims to develop an academic home for implementation research that was lacking, and we're really sort of lagging behind our other peer institutions that had made substantial investments in implementation science and research. It's to provide trainings in implementation science, and I'll share with you about two of the monthly training opportunities that we have that are available virtually and one in person. And then also create awareness to the field and its multifaceted applications across Dartmouth. And what I love about the center and what we petitioned for with the dean when we launched this is that we didn't want to only focus on applying implementation research in the context of health and healthcare, but we wanted to be versatile to bring the methods to other fields like education and state and social services and agriculture and energy. And we're collaborating with faculty across campus and our School of Engineering, School of Business, and Irving Institute on those other applications of leveraging the implementation research methods in fields outside of health and healthcare, which is really exciting. And we're also expanding strategies used in the implementation science or beyond medicine. That's what I spoke to about. So this gives you a general introduction to the center activities that we're doing. We offer monthly fundamentals sessions like you're doing here that are completely virtual, and those are usually held on the second Wednesday a month from 12 to 1. We've had some gaps due to the federal situation and talks being canceled, so we've had some bumps over the past year, but we try to do it monthly. And then we also offer Works in Progress, which is a smaller group of people. This is a hybrid form where we have in-person as well as virtual attendance to focus on developing research in implementation science. And we've had great Works in Progress that have been both inside in health and healthcare and outside. We've also brought in guest speakers and a lot of federal guest speakers, and even Yolanda Perkins and Rebecca Hornack from the National Implementation Research Network to focus on what they're doing in educational interventions outside of health and healthcare, which has been great. So this looks a little bit at the engagement of our center. So we've had almost 1,200 attendees on our educational sessions through fundamentals and Works in Progress. We've had 415 unique seminar attendees. So people are coming multiple times, which is great to see people engaging in our programs. And we've collaborated on now, I think, over 50 different grant collaborations in the last year and a half. We competed for COBRE Phase 1. We're still waiting for that. Hopefully get that funded this year, but things have been slow. We did receive 4 just-in-time notices, but still no funding notice of award. But we're hoping that that will be funded and will be a broader resource for the New England states participating with NIGMS and the COBRE mechanism. So stay tuned for that, but we hope to be able to provide that. That will also help provide a more formal implementation research scientific core that can foster broader collaboration and consultation in implementation research and research designs. We're also building implementation science methods in our medical education curriculum. If any of your programs with UVM or Tufts have interested with that, please feel to reach out. We're happy to see what we can do to try to incorporate implementation science training in the med ed curriculum. Right now, we're doing this through the Making a Difference or MAD curriculum projects, and also open to dual degree options for med students to either try to take our program virtually over 2 or 3 years, or while doing medical education, or taking a gap year and doing it in 9 months. So we've launched a new master's in implementation science, the first standalone master's program in implementation science, which is exciting. And it's offered full-time over 9 months, 3 terms, or half-time over 18 months. So doing 6 total terms. It's fully online. And what's really exciting is that being fully online, we've had the flexibility to bring in international experts in implementation research. So 60% of our faculty are external to Dartmouth, which includes Omar Galarraga from Brown, Jeff Curran from Nebraska, that's developed the hybrid designs, Yolanda Perkins from National Implementation Research Network that focus on educational interventions, Rachel Tabak and Sarah Malone from Washington University focus on implementation research methods and context specifically. Andrew Quanbach for implementation strategies coming from Washington. And Caitlin Reardon, who essentially is really the developer and maintenance person for the widest used framework in the field, which is the Consolidated Framework for Implementation Research, or CFIR. We'll be teaching our mixed methods and qualitative course. And Liz Murnane's coming in from our School of Engineering to teach human-centered design, and then our other co-directors from our center. So I'm going to move on now to give sort of an implementation science approach to prevent contrast-associated acute kidney injury as sort of our clinical application of how we can leverage implementation research methods for complex problems. So to give you a little bit of a background on acute kidney injury, or we'll call it AKI. So essentially what happens is mostly due to contrast, or due to the fact that patients come in with extended NPO orders and come in essentially dried out and volume depleted. Once they are exposed to contrast, it's very difficult for the kidneys to filter it out and can actually reside there for over a week or more. So patients might see a short-term loss in renal function that fully recovers. Some might have more substantial loss in renal function that partially recovers, and that patient will accelerate much more quicker to a higher state of CKD, or chronic kidney disease. They might go on short-term dialysis and progress more to acute on chronic kidney disease, or go directly to end-stage renal disease and not recover, or other major adverse events, including death. We've documented all of those complications quite robustly over the last 15, 20 years. This is a nephrogram that actually shows the kidneys with the contrast agents lighting up. This is the safest contrast agent that's used in the field, Visopaque. And you can see that at bolus and then up to about a week or so later, it's still present and then finally clears out after 2 weeks. And so this is an issue where, especially for volume depleted patients, if they're not pushing fluids, can cause ongoing kidney injury. And this is essentially a diagram we developed for one of the first chapters on acute kidney injury in cardiovascular interventions textbook, and really sort of shows sort of the pathophysiology of what we feel is the contrast causing acute ischemic injury due to the chemotoxicity that's causing acute tubular necrosis, and also results in the release of free radicals where the cells are attacked, and that creates oxidative stress and cell death. Acute kidney injury has also been sort of considered sort of like the first domino to fall in a bad series of events, where through robust biomarker trials have sort of looked at kidney injuries, or really being, as Bob would say, the canary in the mine, is the sort of first signal of bad things happening. And then these biomarker trials and clinical trials have also documented that when the kidneys fall, then you start having other multiple end organ injuries occurring as well. This is some additional descriptive work that we've done that shows in calf patients and population match controls in the national VA, so that when you have acute kidney injury during a cardiac catheterization procedure, you have a twofold increased risk of progressing to a worsening state of chronic kidney disease, more than a twofold increased risk of going on dialysis, a twofold increased risk of subsequent myocardial infarction, and I think a 2.5 increased risk of mortality compared to patients that didn't get acute kidney injury and against population match controls with like 5 or more similar comorbidities. So it's a big problem. We've also done meta-analyses looking at contrast agents and exposure to the amount of contrast, and published on if you exceed a safe dose of contrast, which is here at the top of the page of 5 milliliters times the body weight in kilogram divided by the baseline serum creatinine, what we call the maximum acceptable contrast dose equation. If you exceed that, we show every 50% increase above the threshold is a dose response relationship for developing acute kidney injury. Hitinder Gurm from Michigan came up with a more simplified equation, basically doubling or tripling the baseline creatinine clearance as a threshold. So either can be used, but essentially, if you exceed those thresholds, then you're putting the patient at higher risk of AKI. So we try to work with clinical care teams in the cath lab to minimize contrast as much as possible. We've also done prophylactic meta-analyses looking at the multi-randomized trials on whether to use sodium bicarbonate or normal saline as for prophylaxis to bolus the patient before and after the procedure. And essentially, what we decided to work on with sites that both of them work, and the point is to really just push fluids. And so we did all of this work, but essentially what was lacking is that there's numerous clinical trials and meta-analyses and observational reports, but really no implementation science and no quality improvement initiatives to really do something beyond just doing these trials to make a difference nationally. So the first thing we did was we published this call to arms paper and published in BMJ Quality. And this was part of the, as many of you probably are aware of, the sort of still existing, but prior Northern New England Cardiovascular Disease Study Group that all of your institutions have participated in and continue to participate in, that represent 10 of the medical centers doing cardiac catheterization in our tri-state area, which represent, I think it's like 98% of the cath procedures. And what we did was we did a risk-adjusted analysis to look at the variability of AKI rates across our region. And we found two top-performing sites, which was Fletcher Allen, or UVM now, and Bangor were the top-performing sites in our region, and were statistically significantly performing better than all the other 8 sites in our region. And we want to understand why. So we did some mixed methods approaches to dig in to understand what protocols were being used, what else was being done that was achieving this sort of benchmark performance for the region. So what we did was first we interviewed teams at every institution and tried to collect so essentially what they're doing. One thing was the top 2 performing sites had changed their NPO orders to be 2 to 4 hours before the procedure, which aligned with the anesthesia guidelines that was released in 2004 that changed it from after 10 p.m. or after midnight to 2 hours before the procedure. The other sites were not adopting those newer guidelines. I think the guidelines had been in place for at least 5 years at that point, or if not more. So the 2 top performing sites were allowing patients to essentially self-hydrate up to 2 to 4 hours before the procedure, which is a big deal. They also had mandated IV fluid orders for either normal saline or sodium bicarbonate, as we showed in the meta-analysis. It really doesn't matter what you do, it's just important to push fluids. But what was interesting is that they mandated aggressive fluid protocols to do a 500 to 1,000 cc bolus of fluids before the procedure as well as after. And all of the other sites was essentially still write-in orders. So each interventionalist had to write in how much fluid they should get before the procedure, how much fluid they should get after the procedure. And there was a barrier of concern of like, how do we manage the heart failure patients? But nephrologists and others were not included in how to sort of manage that concern over giving too much volume to heart failure patients. And if you speak to a nephrologist and say, do what you need to do, and we'll pull the fluids off later. But all the other sites essentially had these write-in orders. So nothing was mandated. And when you actually walk the process with the patients, IVs would be hung. And even if something was written in for 1,000 cc's of fluids, usually the fluid was just and bag was hung there as KVO and not hooked up to a pump and pushing aggressive fluids. So the top performing sites mandated this and had systems in place to really push fluids aggressively. And they also did it for post-procedure fluids. So we developed sort of this protocol from the benchmark sites to reduce the variation AKRIs across the sites. We trained sites to avoid NPO after midnight and use 2 to 4 hours to the procedures. So they needed to engage their departments of anesthesiology to change these NPO orders. They needed to establish and standardize pre and post procedural IV fluid orders. At the time, people were using high dose N-acetylcysteine or Mucomyst, and they're also sort of pushing for clinical champion roles as well. So this led on to us publishing our prospective interrupted time series study using this work, but also delivering it through a learning collaborative with the Northern New England sites, which is essentially really well set up. So we're able to meet with site teams on 3 times a year during the N&E meetings, but then also met virtually as part of a learning collaborative to work together and also provide peer-to-peer coaching to roll out these protocols. So we worked on this for a number of years, and that included over 21,000 non-emergent consecutive PCI procedures in the 10 hospitals. Our baseline period was 2007 to 2008, and then we started aggressively working with these sites using learning collaboratives and using the N&E meetings to train people. So our intervention period was from November 1st, 2028 through June of 2012. So we also did interviews and did qualitative analysis with the teams, and some things of interest sort of came out of that. At the very beginning, we kept hearing from sites that there's really no specific protocol a doctor has to utilize in terms of the amount of hydration. We heard that again and again and again. Basically, there's no system or standardized protocol in place. So that was something we had to fix. And the other thing was unlearning old routines. So everybody has their own little routine, and that was one thing we had to unlearn in the process. And the other thing was dehydration that I spoke to before. Patients were coming in really dried out. So we use learning collaboratives, we use the N&E, and looking at all patients, we were able to reduce AKI by over 21%, was statistically significant using interrupted time series analysis. And so the intervention sites are in the blue line, and the benchmark sites, the top performing sites, are in the red line to sort of track to see how they were performing during this period of time. And this was specifically looking at the CKD population. So we saw a 28% statistically significant reduction in the CKD population, and we brought them down to the same performance as the benchmark sites. So we did multi-level hierarchical modeling, and that's how we came up with our significant findings. And that was, also including risk adjustment for these variables on the right. We also did interviews and qualitative interviews and analysis throughout the trial. And these are some things we picked up about around sort of contrast use. One interventionist said a little bit more attention to how details to cut your contrast volume. For me, I say to myself, how long can I go? It's like one of those little games we all play in the cath lab to keep us from being bored, is trying to lower our contrast volume. So it really became a competitive thing, which is, good. So, and then also every time I use contrast to recording, we've done intervention cases with as little as like 35 cc's of contrast. And so you do a lot with one push and so on and so forth. And then by the end of the trial, we kept hearing from each intervention site that was participating that really the culture changed. So I heard Dr. X the other day stopping a case, and the case was going to further, but because they had a contrast load exceeding the max, stopped and brought the patient back a couple days later. And then others constantly kept saying at the end of the study, the change in culture is clear. People care about this now. And so this is essentially the protocol that we developed to essentially adopt the benchmark hospitals, standardize order sets, reduce MPO orders to only 2 to 4 hours per procedure, stopping nephrotoxic drugs prior to the procedure. Sites started developing readiness checklists and actually included volume status and fluid status of the patient in their JCO timeouts. They would even, some sites were delaying procedures to allow the fluid bolus to complete. So if a patient was in the cath lab holding area and they didn't receive their full bolus, they delayed the procedure. So that really got the site to work on getting those boluses done on time. They also worked on limiting contrast and even incorporated, I think this originally came from our Bangor site, that they had established patient education materials to say, hey, you should drink as much as you can before your procedure, before the 2 hours before, and when you go home. And that actually matched some great non-inferiority trials that were in place that showed that using clear fluids or green tea or water, that self-hydration is actually non-inferior to just pushing IV fluids. So that's something, it's a way to empower patients to do some sort of self-prophylaxis to prevent against acute kidney injury. So this went on to be funded by the NIDDK and an R01, where we used our NNE experience and our large pilot to move forward to a hybrid type 1, very robust and rigorous factorial randomized trial in the national VA to focus on implementation and sustainment. So this was done with myself and multiple PIs, Rick Solomon, who's at UVM, and Michael Matheny, who's bringing clinical informatics. And I'll talk about how informatics played a role in the dashboards that we developed. And he's at Vanderbilt. So we conducted this 2x2 factorial trial. We brought in our learning collaboratives that we did, but we also tested it against, instead of just usual care, something we call technical assistance. So they had one-on-one, the same number of touch points as the learning collaboratives did on a monthly basis, but they had one-on-one technical assistance with implementing our protocol, but they were not coached as they would be in a learning collaborative. And the learning collaboratives had 5 sites to learn together and work through a curriculum. But what was really beneficial there is they provided more peer-to-peer coaching of each site to help them overcome the barriers to standardizing protocols and preventing AKI. We did the intervention over 18 months at 20 sites in the VA, and then removed those implementation strategies, technical assistance, and learning collaboratives. And then I need to say that one of the technical assistance clusters and one of the learning collaboratives received an audit and feedback dashboard that I'll share with you. So that's where we get this 2x2 factorial design. So we removed all those interventions, and then we followed the sites again for another 18 months without doing the technical assistance or learning collaboratives. This shows our national sites. And we published this in 2003 in CJSON. This is our visual abstract, where we took collaborators or assistants with or without the surveillance dashboard feedback. And in the end, we received a 46% statistically significant reduction for those in the collaborative with surveillance. So I went over, this is the same protocol I shared from our CIRC outcomes paper, and we essentially developed an 18-month curriculum to work through the clinical topic as well as a quality improvement topic for learning collaboratives and technical assistance. So I shared with you about the technical assistance and learning collaborative structure. This action or implementation phase are the areas that we focused on with the teams. And they also did monthly measurement of some of these process measures as well as their outcomes. And we specifically wanted to focus on contrast volume and the IV protocols. But then two of the clusters received the automated surveillance reporting or this audit and feedback dashboard. And the dashboard provided monthly adjusted rates of AKI for their site. In the top right, it provided benchmarking, so where the site was performing against the national average, against the VA region or the VA VISN that the site was embedded in. So they could use that for benchmarking to see where their current performance was for the last 18 months. We also provided more of a surveillance plot. This is in the bottom left is a risk-adjusted sequential probability of ratio testing plot. It's often used in like transplant procedures and things like that. But as the graph goes up, it goes up with more sequential occurrences of the event. In this case, it's acute kidney injury. And if it crosses the upper line, then that's an early indication of essentially things going badly at the site. And in the bottom right, we had a patient registry where they had their contrast dose, their baseline creatinine clearance, whether they're above the contrast maximum acceptable load or not, and then other process measures. And that actually linked directly back to their VA cath lab system to do more root cause analysis. So we randomized 20 sites. We only lost one site after randomization. I think that was Albany, because they had closed the month after we did randomization before we actually started the trial. Overall, across the 20 sites, well, 19 really, we had 4,500 procedures. 1,300 had pre-existing CKD, and they are pretty well balanced for comorbidities and patient demographics. In the end, as I showed you with the visual abstract, the collaborators with the surveillance feedback performed the best compared to the other sites. And what we found was a statistically significant 46% reduction in AKI. And that was true with or without statistical adjustment and different ways that we adjusted for things as well. We did not see a change in the CKD population, likely because more preventative measures might have been used for the CKD patients as being considered higher risk, and we saw more benefit in looking at all patients because they might have not been receiving as many of the preventative practices or order sets. We also looked at AKI up to 30 days after the procedure and still found a 40% statistically significant reduction in AKI. This sort of looks at fidelity measures. We do this in the field a lot to sort of, okay, are they actually using the thing that we want them to use? So we looked at, how often are they actually implementing interventions. So the three major sort of bundled interventions we focused on were standardizing order sets, whether they increase the IV fluid orders, and then how were they making efforts to reduce contrast volume in their new procedures. We also looked at call attendance as well as access points for the dashboard, which are in red. And so the learning collaboratives with the surveillance feedback had the most dashboard hits and also had the most calls attendance, so highest fidelity. And they also had the highest fidelity for actually implementing these three interventions that we collapsed everything into. We also identified through qualitative interviews, identified sort of barriers to rolling out these protocols. And those barriers included sort of lack of time for hydration, resistance to change amongst the staff or leadership, lack of a set protocol, provider hesitation to have a standardized protocol. Most of that was derived around concern for what do we do about the heart failure patients. But when you talk to nephrologists, they're like, just do it and we'll figure it out later. And sometimes lack of buy-in from providers. And then we also looked at facilitators, so things that were sort of helping these protocols get implemented. These included sort of nurses being receptive to the change, nurses assuming responsibility for preventative strategies, and we saw a lot of sites taking real ownership of implementing and standardizing these practices. Strong communication easy to use order sets, continuous education that was being provided through the collaboratives, buy-in from team and also at the organizational level, increased awareness of the patient safety issue of acute kidney injury, close relationship with nurses, strong team culture, automating the order set, so standardizing and automating the fluid orders, and training for the study. Then we removed our implementation strategies, followed the sites passively for 18 months. This went for about another 4,100 patients, and followed them for 18 months. And we found a statistically significant 40% sustained reduction in AKI. And we even looked at that 30 days, and that was still sort of sustained at a 40% reduction in AKI. So when we look at the implementation and the sustainability phase, we had a high degree of alignment that we were able to reduce acute kidney injury by 46% in the implementation phase, and also statistically significant 40% sustained reduction, which means that once a site worked on standardizing order sets and training and understanding around how to prevent AKI, those interventions were sustained over a longer period of time. We just published our cost effectiveness analysis that showed that the collaboratives with surveillance was both our lowest cost intervention and also had the best quality adjusted life years from the trial. So it became our referent group, and all the other interventions were slightly more expensive and had slightly lower quality adjusted life years. And that's now published in JAMA Network Open as of last week. So overall, Improve AKI is a randomized implementation trial and demonstrates that the combination of learning collaboratives with surveillance significantly reduces acute kidney injury by 46% and sustained at a 40% reduction after additional 18 months. And the combined learning collaboratives and surveillance and team-based coaching intervention is an effective and scalable intervention to establish aggressive prevention protocols to prevent AKI. So that's our visual abstract again that I showed you before from CJASN. And I want to just bring you back to, so this was a hybrid type 1 trial. And now that we both have the efficacy and the sort of established effectiveness evidence from our hybrid type 1 effectiveness implementation trial, we can now move forward to do more of a dissemination study to more aggressively move out our interventions using the learning collaboratives and surveillance feedback using a hybrid type 2 or hybrid type 3 design. And what we're currently working on is trying to secure federal funding to move this into a randomized step wedge design where we are going to be randomizing 30 to 50 medical centers participating in the National American College of Cardiology Cath PCI registry to receive the learning collaboratives with surveillance feedback in both an implementation phase as well as a sustainability phase. So the ACC has agreed to partner with us on that. And so now the easy part of just securing funding to move this hybrid type 3 randomized step wedge trial moving forward. So I'll leave it there. This is just, again, the summary of our educational opportunities through the Center of Implementation Science at Dartmouth. So thank you.
Thank you so much, Dr. Brown. That was wonderful. I already see a question coming in the chat from Donald. Jeremiah, many thanks for the overview, the details, and the example. A GME question. Many RCs for our ACGME residency and fellowship programs require either research or QI projects. Can you speak about the challenges and benefits of bringing implementation projects in as an alternative conceptual perspective?
Yeah, so that's a great question. So I think bringing implementation research designs and really the multidisciplinary methods that are used in the field for really successful studies, and it's required for funding, would be a great integration into GME research training and residency. What I have observed at Dartmouth and other places is often quality improvement and local sort of process of change are done, and you're using PDSA cycles, you're trying to develop your protocol and test it. but rarely does that actually move beyond the local setting. So you're having some local change, and there's even a large number of usually pilot programs that fund sort of local specific implementation or improvement projects. What I think implementation research does and has the ability to sort of broaden the focus of that to say, okay, instead of doing this in one location, what if we do these local QI projects or research projects in more than one institution? We try to learn from each other about how the process is different in different institutions and different clinical situations, but then also use the implementation research like hybrid designs as something to work towards to foster collaboration at multiple institutions that will increase the ability to get extramural funding for those types of projects. But if you keep it more only at sort of that local context and setting, it's really hard to move that local experience forward to get some extramural funding and move that work for broader evaluation and ultimate dissemination. So leveraging the NNE CTR or NNE cooperative and doing things in more than one clinical location would be a great place to start.
Thank you. We have one more question in the chat, and then I see Gary has his hand up. So Brittany asks or says that she is wondering about a couple of things about the DHMCMS implementation program. Do you feel that this is an appropriate program for practicing early career research motivated MD interested in implementation science? And is the workload something that's possible while practicing full time with a heavy clinical schedule?
Yeah, that's a great question. So what we're seeing for enrollment for the program is um, almost all of the students coming in are early, but more presently established mid-career professionals. It is feasible to do so. That's why we're offering sort of both the full-time or the half-time option. The half-time option, doing it over 6 terms instead of three. Um, the workload is around 10 to 12 hours per week, and you'll have 10 weeks in each of the 3 terms. The first year would be you'd have one synchronous session a week for 90 minutes. That's from 12 to 1:30. And it would be on Tuesdays in the first year, on Thursdays on the second year. And we've split out the curriculum so that they sort of build on one another. So you can either do it full time and you're benefiting from both of the sort of concurrent courses, or you can sort of do them in sequence. So the amount of work is around 10 to 12 hours per week. It's not only 90 minutes of synchronous time, and we're sort of set an expectation that you're attending about 60% of the sessions to receive credit. And then full time, it would be twice that. So we're estimating closer to 30 hours per week. So but the large majority of the enrollees are established mid-career professionals. We're also seeing early career professionals. But we're not seeing sort of the recent undergrads that are really just trying to use it as a stepping stone for med school. I'm sure that will happen at some point. But it's largely a very diverse working group and international. So we're bringing in physicians and researchers from Haiti, Peru, Kenya, and across the US, both inside healthcare as well as outside of healthcare in education, law, agriculture, state and social services, as well as the healthcare setting.
Wonderful. Gary, go for it.
Sure. Over the past few years, there has been an increase in in bringing up clinical investigation and clinical trial capabilities into primary care settings, and that becomes particularly important in rural North New England and obviously beyond as well. So, my first question, you can get partial credit on this, don't worry about it. The first question is, is there any specific training that is being incorporated into your program to be able to go ahead and to try to make that adaptation? And secondly, are there any ongoing initiatives trying to work with primary care settings?
That's a great question. So A couple of things. So the program will definitely provide applications from the various faculty in their courses at different levels of implementation research and their focus. That would include primary care applications. And in terms of research, our research team has an R01 funded in COPD and specific. So this bridges both the clinical informatics work we do and implementation research. So we're developing structured and unstructured clinical informatics predictive toolkits in the ambulatory COPD population. So this overlaps somewhat with primary care and somewhat with outpatient um, clinics as well. And we're trying to predict healthcare utilization amongst this ambulatory COPD population. When we have the toolkit embedded within our Epic system, the intent is to do a stepwise trial to train clinical care teams in the ambulatory care setting to use the informatics toolkit. And we're going to do it in an implementation research approach guided by frameworks and mixed methods approach to understand how we can train clinical care teams to use an informatics toolkit and also see if they're actually using it, and looking at their clinical notes and things like that. So that's one example of how we're bringing both our informatics and implementation research to ambulatory care.
And looking ahead, uh, working with the primary care practices that are affiliated with the academic medical centers in northern New England, it obviously would be Dartmouth, UVM, and Maine Health. But are there any aspirations to be able to work with the non-affiliated primary care practices? Because these are often neglected and probably have minimal connection with some of the state-of-the-art approaches.
Mhm. That's an excellent idea, and I believe Tim Burdick actually pulled me aside this morning at a local conference we were having to specifically talk about that and how we can bring implementation research to the Northern New England Co-op specifically around primary care practices. So I think he's going to try to kick off of a discussion of how we can leverage implementation research experience from our center and bring it in to the NNE Co-op and NNE CTR. So,
And
and
that's actually the person who I was thinking about, and that is the group that I was thinking about as well.
great. So I think those meetings and conversations will hopefully start to take place soon. And feel free to also reach out, and we're happy to set up a meeting and talk and try to plan out how we can address some problems in primary care delivery and focus on guideline or evidence-based uptake in that setting.
Well, you raised awareness, when you gave the talk here at UVM that I could 300% assure you.
There's one more question in the chat from Donald. Have there been successful implementation research and engagement projects in low and middle income countries?
Yes, so the NCI has a fairly substantial amount of LMIC focused implementation research mechanisms. So on our SIHH study section, that's probably about a third of the grants that we're actually review are implementation research trials being done in LMICs. So NCI probably is funding the most, and you can just look for those LMIC mechanisms. They all require rigorous implementation research designs and evaluation. NHLBI through Citrus and their implementation center is doing some LMIC work. It's a little bit more nationally focused, but not quite as much as NCI. And then some of the other institutes have some LMIC focused areas for doing implementation research. So there's a broad spectrum of cancer prevention, cancer screening, and for NHLBI focused areas for hypertension management and LMICs, doing remote echocardiograms, like things like that, that they're trying to use implementation research designs to roll out the adoption of some of these largely screening programs and then how to scale it through the rest of the country through collaborations with the local ministries of health and sort of things like that. So there's a broad amount. Actually, you can go on NIH Reporter and just put in implementation research is sort of a search term. And you can then go to a map and see all of the federal funding that's been done globally for implementation research, and it's quite substantial.
Wonderful. Well, I think that that was all the questions in the chat. And probably, does anyone have a last question?
Just appreciation, I mean, for a very, very informative overview of a program that obviously is making a difference.
Yeah, well, thank you so much. It was an honor and privilege to be able to share with you what we're doing for the center and our educational programs, and a little bit about how we're using these methods in extramural funded research. And look forward to participating more. Sheila, I think there's a note in the chat about just getting information around our training programs, and we can get that out to you soon as well.
Thank you all. We'll see you at the next spring seminar session. Appreciate you all attending. Thank you.